Happy Friday, everyone. My name is Ashley Johnson. Welcome to NAHU's Bridging HIV and SUD Innovation in the Field webinar series. Today's session is Bridging the Access in Care for Those Experiencing Homelessness. We invite you to use the chat to engage with your fellow attendees. To start, please add your name of your organization, and for our icebreaker question of the day, how many people attending are scuba divers? Throughout the session, please use the Q&A pod to ask your questions. The speaker will address them at the end of the presentation. Today's session will be recorded and presentation slides will be added to NAHU's website as a resource. You will receive this information in the post-webinar email that will be sent out through Zoom. You can also visit NAHU's resource page on the website to find this resource and to view past sessions. NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, AETCs, that support the AETC program mission. Established in 2010, NAHUD supports the AETCs, a component of the HRSA-funded Ryan White HIV and AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations in order to promote and educate on the work of the AETC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery, and harm reduction of opioid use disorders and other substance use disorders through the provision of locally designed education and training. Visit the website to submit a TA request, read case studies, see featured resources, check out upcoming ORN events and training, learn about ORN workshops, addressing health disparities, and more. A post-evaluation survey will be emailed to you after today's webinar and must be completed within 2 weeks to receive CME, CNE, Social Work CE, or a certificate of attendance. After 2 weeks, once the survey is closed, it will not be reopened. This link will also be added to the chat towards the end of the presentation. The minimum attendance requirement to receive CE is 60% of today's webinar. Participants who accrue less than 60% will not be eligible for CE. If you are a phone participant, please contact Liz Lazo to verify your phone number and to receive the evaluation link. Certificates will be emailed within 3 weeks of completing the evaluation. CE credits issued for participation may not apply towards license renewal in all states. Each participant is responsible for verifying the requirements of their state licensing boards. Today, we have the pleasure of having Janelle KK Osman, KK founder and CEO of Care Beyond the Boulevard, or CBB, is leading the charge in equity and access for those experiencing homelessness in the greater Kansas City metro. KK founded CBB in 2016 with a desire to bring healthcare to those living on the streets. This was born out of serving at a food and clothing ministry in Kansas City and noticing people continually coming up for help with medical-related concerns. She vowed to start a clinic in that ministry that would provide a link to services and basic health care to those at great risk for health problems and poor access to health care. KK graduated from nursing school in 1992 with an associate's degree in nursing and worked as a critical care nurse for many years. She completed her bachelor's degree in nursing in 2014 and her master's in nursing, obtaining a degree as a family nurse practitioner in 2016. And without further ado, I'd like to turn it over to our presenter.
Great, thank you. I am going to share my screen with you. Thank you so much. So the scuba diving question was mine because I'm an avid scuba diver. I liked the scuba curious response. That was awesome. And then the person who said it's a perfect escape from the world. That it is. So um, I am sharing my screen. Hold on 1 minute. Sorry. I'm getting a feedback. Okay. Sorry about that. All right. Ashley, can you see my screen?
Yes.
All right, perfect. Right. So, thank you for having me. I'm thrilled to be able to present to you all today. I know that you guys have had a couple of presentations on street medicine, and I think it's really good to get different perspectives from different organizations and really learn more about the people that we're taking care of and that many of you as providers are also taking care of. For me, I have no disclosures. I am the founder of Care Beyond the Boulevard, and I came into this work quite by accident. So the scuba diving question comes back around because when I was in NP school, my plan was to move to the Caribbean, open a dive shop, and then have a clinic on the side. That I did this instead. So um, I was volunteering at a soup kitchen, and every Monday night, people would come to me with health questions. And I lived in a part of the city that does not have people who are experiencing homelessness, not a lot of them anyway. And there was really adequate health care for everyone. And so I was like, well, isn't there healthcare around here? And I started doing some research, and I learned that no, in that area where the soup kitchen, there was not. And there were health clinics, but access to them was fragmented. And I started doing research on people who are experiencing homelessness, and I learned how fragmented their healthcare is, and how much there is lack of access to consistent compassionate healthcare. So I decided that when I finished NP school, I would start a clinic, and started doing some research, and then discovered the street medicine movement and decided that's what I wanted to do. So I graduated from NP school in 2016 in January, and our first clinic was in March that same year. And so 10 years ago, next month is our 10-year anniversary. And again, was not my plan for my life, but I'm really lucky to be able to be where I am and doing what I'm doing. One thing about me is I don't read slides to people, so you have to pay attention and read. I figure everyone can read, and hopefully I can give you some content outside of what's on the slides that can deepen the information that you're getting. So these are the learning objectives for today. And we'll get started. So one of the things that I always want to talk about, I want to lay out that people fully understand like healthcare services in the United States. And as healthcare providers, most of you know, like these are the options for people who are experiencing a need for healthcare. And this is not all inclusive, but this involves, this includes most of the ways people in the United States can seek healthcare to get their needs met. So then I want to look at like, what about people who have insurance or people who are working? And you'll see if I toggle between these two, it doesn't really change. Not all healthcare or not all places of employment have occupational health, and I recognize that, but a lot do, and it is an option for people who are working or people who have insurance. So there's not a lot of difference. But what happens when we're talking about people who are poor or uninsured? You lose a couple of those options, and then a couple more are really questionable. Like, again, occupational health is questionable, and primary care clinics, do they know how to seek their a primary care, and can they seek primary care if there's a charge for those services? But then when we talk about people who are experiencing homelessness, those options reduce again. Now, one of the things that you see that stands out here is emergency departments. And so just so you know, I used to be an ER nurse. I was a trauma nurse practitioner, and we would see people who came to the emergency department who were experiencing homelessness, and would use the ER as their primary care clinic. But as I have gotten into this work and spent more time here, I truly understand why that happens. And so the options for people who are experiencing homelessness, they're greatly reduced when you're talking about accessing healthcare services. And so what we work to do, what our team works to do here in Kansas City is to bridge those gaps. It is not my intention to be the primary care provider for my patient population. And some straight medicine teams do that, and that's fine. Like we all look a little different depending on the needs of our community, which is really great when you're talking about street medicine. It's really geared to the community that we're serving, which is very important. Um, my goal is not to be that primary care provider because we do have gaps in the services that we can provide. Now, for many of my patients, we are the primary care provider. We did a survey of our patients last year, and 75% of our patients don't seek care from any other places. So that's kind of a baseline of like, where people can seek services to get healthcare. And you'll see, and you saw that for homelessness, there's really a lack of access to care. I also think it's important that you all understand the types of homelessness. And this probably was covered by Brett and Liz if you were in on their presentations. But just so you all know, we've got sheltered homeless. Those are people who are living in hotels. Now, people may live in hotels, they may pay for them, or there may be an agency, a church, or something that is paying for it, sometimes short term, sometimes long term. People who are couch surfing, those are individuals who are staying with a friend, staying with family, going from couch to couch. There are also people who are sheltered living in shelters. And Kansas City lacks enough shelter beds for the people who are living outside, as do many cities in the United States. And then we have the unsheltered homeless. Those are the people who are living outside. Every city has a different landscape of their homeless communities. Some cities have huge encampments. Actually, in Kansas City, having an encampment that is huge is very uncommon. The encampments in Kansas City, if I see an encampment with 5 or 6 tents, that's actually a lot. There are some big ones; they frequently get swept, moved on. But the unsheltered homelessness, those are the patients that we focus on. That's our goal, is to provide healthcare to those who are unsheltered. Now, we do not turn anybody away in our organization. We don't charge and we don't bill for services. But if we have patients who have insurance, we will still see them. And we, like I said, work to try to get them into primary care. Although for most of our patients, they're a little resistant to that. And we'll talk about why shortly. So this is just a snapshot from 2022 and about the number of people experiencing homelessness in the United States. Actually, new data is showing that between 23 and 24, homelessness increased in the United States by 15%, as it did from 2024 to 25. Now, this data is not always accurate, and I'll explain why. So every year, there's something called a point-in-time count. This is sponsored by HUD, and that is how we count the people who are experiencing homelessness in the United States. It's a very flawed way of doing this for several reasons. Number one, it is done one time a year. Sometimes people do it too, but the general data collection is done in January. For those of you who live in cold weather states, January is generally the coldest time of the year. For us, we actually missed our cold snap in our point in time count by about a week, which was good because we were able to reach more individuals. But going out one day a year to count people who are living outside is not capturing the true picture of what's going on in any given city. So there's that, number one. Number two, it doesn't count people who are couch surfing or living in hotels. Those individuals are still homeless, but they're not counted anywhere. And then probably the biggest problem I have with the way this is done is that we go to people and we have our iPad and we have a whole list of questions. The questions used to be pretty straightforward and pretty simple. That's grown. The questionnaire has grown to take a lot more time, but volunteers do this. So the problem with that is that when you're talking about people who are experiencing homelessness, you have to earn their trust. And that's one of the reasons that street medicine teams are so important, is we're earning the trust of the people to help with them with their health care. But when you're doing a point in time count, Street medicine teams, outreach workers can't do it alone because it's a 24-hour process and it's very labor intensive. So they call in volunteers to get trained. So you have someone who's walking up to an individual with an iPad in their hand saying, "Oh, are you homeless? Yes. How long have you been homeless?" Asking these, then it gets into very personal questions. Do you have HIV? Do you have a substance use disorder? And do you have a mental health disorder? So statistically speaking, the numbers that we get are flawed. When they talk about people who are living outside with mental illness, you can look it up, and sometimes it says 40%, sometimes it says 60%. I say I've been doing this 10 years and I haven't found anyone that doesn't have some type of mental health disorder. Um, so we have data. It's not perfect. It's the only way that we have right now as collecting data on people who are experiencing homelessness. So the other thing that I like to throw in is that for ACEs scores. So for those of you who know, ACEs are adverse childhood events, and we have a questionnaire that we ask individuals, and it's all related to prior to the age of 18. And there are 10 questions. The highest a person can score is 10, and the lowest is 0. And these are questions related to prior to the age of 18, did anyone in your home abuse you? Did you feel neglected? Anyone use drugs? There are several questions that are asked of this. And so we did a study in 2020 into 2021 about ACEs score, trying to figure out, like, do our patients have higher ACEs scores? We knew that they did, but we needed the data. So what we did is our medical director has a concierge service in a very exclusive area of Kansas City. And so he asked his entire practice to answer the questions. We got a little over 100 responses. And for those individuals who had never been homeless, the average ACEs score was 1.8. But then you go down to the unsheltered homeless, average ACEs score 5. And that's significant that we know that many of our patients have experienced childhood trauma. And so we feel like this is an important piece in the care that we're providing for people and their ability to follow up and their ability to manage themselves. A lot of times I get questions like, what are the things you see in people who are experiencing homelessness? And I see the same things that people who are doing private practice see, any family practice providers. These are the same things. What we see is a higher rate of mental health disorders, HIV, hepatitis, substance use disorders, mental illness. But what happens is you have somebody with hypertension. It's complicated by the fact that they live outside and they may have untreated substance use disorder. They may have untreated hepatitis C. And so what we see is a complication of health conditions because people live outside. But many of the things that we see on the streets are the same things that those of you who are in private practice see with your patients. So when we talk specifically about HIV and homelessness, we know that people don't have the access to care. They're less likely to keep their medications. We've had patients for many years who have come to us and said, I'm taking these medications. They may have insurance, but their insurance pays for the medications, but their bag has gotten stolen. So they lose all of their medications, or they have an appointment and they lose it. And so what happens is that they're less likely to be able to adhere to their medications, which results in higher viral loads. So if we can get people access to housing, specifically speaking about people with HIV, you're going to have improved outcomes in all aspects of their health, not just their HIV, but their complications of their other underlying health conditions. And then having housing also does improve their healthcare engagement. My patient population really has a hard time following up with healthcare appointments for a variety of reasons, and we'll get into that. So the CDC shows that homelessness is a predictor of incomplete viral suppression. So I think it's very important for those of you who are treating people with HIV that you know, like, what is your housing status and what are the things that you can do to work with that individual to ensure that they're getting their medications, that they're getting their follow-up. It does take a little bit more work. Um, Doing this work, taking care of patients who are living outside, it complicates things. But it's worth it if you can help people improve their overall health. And then on the right here, it shows some of the reasons why we see incomplete viral suppression. Our patients who have a substance use disorder, they're using dirty needles on the streets. We know that. Um, we we don't obviously we don't encourage that, but we have seen it when someone has a need, and they're going into withdrawals. It's picking up a needle from the ground and they don't know where that came from and using it or get sick, um, lacking access to care. I'm going to talk a little bit more about engagement and services, but you can see why we see that incomplete viral suppression for people who are experiencing homelessness. Sorry, my screen wrong. Okay. So these are some of the barriers, and this can give you some of the reasons why we see that lack of access to care. So some cities have free transportation, and I understand that. I think most states, and I don't know about every single state, but all of the states that I know of that, I've talked to other people, you have Medicaid transport, right? But Medicaid transport doesn't go to an encampment to pick somebody up, number one. Number two, at least in Kansas and Missouri, Medicaid transport is unreliable at best. We have a medical respite facility where people stay, like coming out of a hospital and they need IV antibiotics, wound care, physical therapy, that kind of stuff. They come to our medical respite and we provide those services. We also work to get them into their follow-up appointments. And we try, if they have Medicaid, to utilize Medicaid transport. About 50% of the time, Medicaid transport doesn't show up. And so then we see that people are not making it to their appointments. And that's what's happening when they're living on the streets. We've tried to arrange Medicaid transport, like from a church. Can you pick them up at the church? Well, if the transporter needs to make a phone, they have to call them. My patient population doesn't always have their phones. They don't, people say to me, well, I see people who are homeless who have phones all the time. Yes, sometimes people who are living outside have phones. Number one, at least here in the metro right now, we don't have anyone that's getting them phone access. So they may carry a phone, but they don't necessarily have service. And they may only have service when they're on Wi-Fi. And so that really limits their ability to communicate, to get their transportation, to get follow-ups. One of the biggest things in taking care of people who are experiencing homelessness is trust in the system. Part of that comes from healthcare biases, and it also comes from patient biases against healthcare. One of our biggest barriers is earning the trust of the people who we're taking care of. And I have hundreds of examples, but I'll give you one really strong example that I have. I have a patient who a couple of years ago, it was in January, and an outreach worker called me and she said, KK, I need you to see this patient. So I need you to see this patient. I think he has frostbite. And I said, okay, I have a clinic tonight. Can you bring him? So we have mobile and stationary clinics, so that we go into soup kitchens and places where people are seeking other services. Healthcare cannot be my patient population's number one priority. So if I can pair it with other services, we have a better response to our work. So we don't have a brick and mortar clinic. But okay, so she said, can you see him? I said, can you get him to my clinic tonight? And she said, he doesn't want to see you. And I said, well, then no, I can't see him. I'm not going to force a patient to see me. We all know that that's not acceptable. And so she said, okay, well, she showed up that night with him. He had agreed to see us. And when he got into us, he had a bag wrapped around his foot. And so I opened the bag and it was full of black liquid. And I said, yeah, this is frostbite. It was one of the worst cases I had seen to date. I've seen some bad ones since then, but this was about 3 years ago. And I said to him, I think you need to go to the hospital. It was obvious that he had gangrene, and I was very concerned about. He obviously needed to have some toes cut off. I was concerned that he would need an amputation midfoot or potentially BKA. And he said, if that's all you're going to tell me, I'm not going to stay. I said, no, I'm very concerned. Had a long conversation with him about, we can debride this. We can debride it twice a week, but I feel like you're going to still lose your toes, your foot, your leg, and potentially your life. I have oral antibiotics that y'all know that doesn't always cut it. But he said, I'm not going to a hospital. I've been treated poorly in hospitals and by doctors in the past. If you don't have any other answers for me, I'm going to leave. And I'm like, no, okay, we'll treat you. That night, one of my volunteers was a burn surgeon, and he walked in shortly after I finished my conversation with this gentleman. I said, I've got a patient for you. So I said, I need you to go debride this foot. And he walked in and he turned around, walked out. He goes, okay, he needs to go to the hospital. I said, I hear you, but here's the deal. And so he said, okay. So he went into debride. He came back about an hour later and he said, I stopped the bone sticking out and he's going to come back and see you on Thursday. And I said, okay. That's not ideal, but that's meeting people where they are, which is what we do. Later that night, after he had left, his case manager called me back and said, KK, he has agreed to go to the hospital tomorrow morning. You guys treated him so kindly. You didn't judge him. He trusts you. He feels like you're not telling him a lie. And he went to the hospital the next day. He ended up having, I think, 3 toes amputated. He followed up with me the next week for his blood pressure. But it was meeting him where he was. It was letting him recognize that I didn't have a bias against him. My team didn't. We're going to tell you this is what we feel like you need, but we're not going to make you. If you choose not to go, you may die from that choice. We accept that decision. He was not under the influence. He was making a conscious decision based on past interactions with healthcare providers. So, it's really important in what we do is gaining trust. And so I think it's important when you're taking care of someone who's experiencing homelessness, you understand their lack of trust in the system. It's not necessarily from you, right? It's not necessarily like they had a bad interaction with you or any of your staff. It goes way back. It goes back to sometimes childhood. Many of the people who are living on the streets were very poor or homeless as children. So these biases that they have encountered go back all of their lives. The other thing that I think it's really important, and I alluded to this earlier, is that people who are experiencing homelessness do not see their healthcare as a priority. Not because they don't care. My numbers will prove differently. Last year, we saw 3,411 patients in 17,500 check-ins. Now, that also includes our case management and all of those, but our patients care about their care, but they're more worried about where they're going to sleep, where they're going to eat, how they're going to, survive another day. Constant survival mode. So I think it's really important that these barriers are true barriers for our patient population. And then what happens is that these barriers perpetuate disparities and inequities. Sorry. So when I first started, I was working at a safety net clinic, and one of the things that was a policy there is if the patient didn't show up 3 times, then they could no longer be seen at the clinic. Well, for our patient population, many of them don't even know that they have an appointment. We had a gentleman one time who came to us. He was Spanish speaking only, and he had discharge instructions from a hospital. And he talked to one of our providers who is bilingual and told him he had surgery on his foot, but he didn't know why and he didn't know when his follow-up was. So he had this great big stack of his discharge papers, which is unusual. Many times my patients don't have those. The instructions were all in English. He had zero clue where he was supposed to follow up. Additionally, the discharge instructions didn't even talk about his toe amputations. That's a whole other story. But it did talk about his follow-up for his CHF that he didn't know he had. He didn't understand it. So he had had appointments that he missed because he didn't have a phone and he didn't know he had the appointments because they were on a piece of paper that was written in English. And so for those patients who have, those kind of situations, they don't know. And then they're not allowed to go back. And many times for the other thing that happened with me at the clinic I was working at, if they were more than 15 minutes late, they couldn't be seen. Our patients they do not have reliable transportation. They rely on other people. So as you can see, many of these items, these bullets, are barriers for our patient population. And if we can change how we think about that and how we approach it, it can help them engage in services. Now, our clinics, we have 10 clinics a week, both mobile and stationary. All of ours are walk-ins. And we understand in today's world, in regular brick and mortar clinics, that can't happen. But what you can do is really dig into patients' histories and figure out, like, is this person living outside? Do we need to, like, maybe adjust some of those hard and fast rules to help walk with them and help get them in to get their services? So, what our underlying policy is going to the people. And that means both physically and mentally. And I gave you an example with my gentleman with the foot. It's meeting people where they are. It's going on the streets, but it's also meeting them where they are mentally. Okay, you don't want to go to the hospital, that's fine, but you need to know these are the risks involved. If you're okay with those risks, we will treat you. And we'll continue to say this. So, street medicine, we want to deliver high quality care. We truly believe that every single human deserves health care, and trying to break down those barriers to get them that health care. If that means going into the woods to provide health care, if that means meeting them at 7 a.m. to take them to a clinic appointment, we work to do that. Because if we can do that, we can also improve their overall health status and their life. We do not do housing at my agency. Some street medicine teams do housing. We do coordinated entry. We help people get birth certificates and IDs. One of the things that street medicine is adapting to the needs of the individual in front of you. And I have had to learn that over the years. When I first started this organization, my plan was to just do healthcare. Someone said, "Oh, you need a case manager." No, I don't. I have 5 now, because what I've learned is housing is healthcare. Now, we may not do that housing, but getting them into housing can be pivotal. We process hundreds of birth certificates and IDs every year, hundreds of them. You can't get housing and you can't get jobs without them. So this is just an example of some of the things that our people who are living outside deal with. Now, this picture was taken in August in Kansas, or Missouri, sorry. And so for those of you who don't know, in the Midwest, it gets really hot here. So a little concerning, right? Chicken sitting out on a table. This is how our patients survive. They had a grill, and the chicken prior to that had been in a cooler. The ice was melted, but it's survival mode. Here's some of the things that we do. So in the background there, that's our bus. That's actually our old bus. It's a school bus that we renovated. We have kind of a variety of ways that we provide services. Kansas City is very unique in that every single night of the week, there is someone out feeding those who are living on the streets. And when I first started the organization, we slung backpacks on, we went into encampments, but we couldn't find anybody. And what we learned is that people were going to picnics. They were going to where food was being served. Remember, it's survival. It's trying to figure out. So they're not going to care about me checking their blood pressure if they haven't eaten. And so we had a bus donated to us, and my husband renovated it, and it has a exam room in it and medication. And so, but we go to people. And so every single one of our clinics has a fully licensed physician, nurse practitioner, or PA. And as I said, I have 10 clinics a week. Many of our providers are volunteers. I work full-time for the organization, but do more administrative work. I do still see patients, probably 2 to 3 days a week at different clinics. I have one of my other employees is another nurse practitioner. She's our clinical director. She sees patients 2 to 3 days a week, and then I have a PA. But all of the rest of our providers, I have 26 providers, are volunteers. Thus one of the reasons we can't bill. But that's a whole other thing. But these are some of the things that we do. You know, someone mentioned a trauma-informed approach. I'm watching the chat, but yes, and reducing risks by saying, can you get to a place to get clean supplies? Can you stop injecting and smoke, which sounds insane. It sounds insane, but it's trying to reduce risks to our patient population. We do offer medication assisted treatment on the streets. We offer MOUD and MAT for amphetamine use. We really work to meet people where they are when they're ready to be treated. Our services, we also have dentistry at one of our clinics. We have an oral surgeon who volunteers every Wednesday, and then 2 other dentists who volunteer. Again, all free. We have psychology services 3 days a week, 2 days at our medical respite facility, and then 1 day at one of our clinics, as well as psychiatry services. And these have all grown out of the needs of our patients, like them telling us what we need, what they need. For medications for our patients, what we've also learned, so as you saw earlier, Kansas has not expanded Medicaid. We're on the border, so we go to both sides of the state line. Missouri has expanded Medicaid. It is also, Missouri is struggling getting Medicaid renewals, particularly for people who are living outside. They forget what address they use. They don't know where things were sent. It's very common. But so for patients who have insurance, we send their prescriptions to the pharmacy. I'm a Medicaid provider. Sarah is a Medicaid. Several of our providers are Medicaid providers, so we can send their prescriptions to a pharmacy. But we also have a pharmacist who works for us, and she does patient assistance for medications that if they can't get Medicaid or their Medicaid is lapsed or whatever. And then we also purchase bulk medications to make sure that we're bridging gaps for people to treat, and this is reasonable medications that we can afford to buy in bulk. There are a lot of medications we can't, but we really work to try to get them their medications, and we work with them to get their medications to them in ways that they can they can take them. So if we have patients, we have had patients who are like, I'm living outside and I don't have a place to store my insulin. We've had several patients, we've transitioned them from insulin to Trulicity. Yes, I know that generally you have a better outcome with insulin, but if they're not taking it, you're not going to have a good outcome, right? And so we have had great outcomes with doing once-a-week injections. They come in once a week to see us, get their Trulicity. We've had patients who we've treated Hep C for, we get their medications, and then we give them a week at a time or whatever they feel like they can handle without losing their medications. So really working with each individual person, truly individualized care. So this is just kind of a difference in traditional offices versus street medicine clinics. Now, street medicine, one of the things that's on here is that it's not billable. It has changed. It is billable for some people, for some agencies. We're an independent nonprofit. And so we don't bill primarily because of our volunteer base. The reason for that is because Medicare does not allow you to bill for volunteer services. In order for me to bill for Medicare, I would have to break my programs down and only have a paid staff seeing patients. It's very complicated. But one of the things about what we do is it's very patient-centered. We do have an EHR, and my providers are documenting to the patients and to the patient's needs. And it's nice because it really is able to focus on the patient's needs instead of focusing on charting. So it is billable. I just wanted to, make sure you know that it is, but there are some limitations. And so, a lot of times I get the question, why do you do this? Now, my smart aleck reaction is because I can, but I truly believe that every single human deserves healthcare, and a community is only going to be as healthy as the poorest and most overlooked. And so many times in our patient population, they are overlooked. They don't show up for an appointment. You know, in a traditional healthcare setting, have lost them to care and no phone number to follow up with. And so they do get overlooked. And I'm not blaming any system, so please don't take it as that. Well, there's lots of systems, but healthcare providers, you can only work with the information you have in front of you from their office visit. And so it's really important to me that we try to improve the overall health of our communities and to make sure that every single person gets the healthcare they deserve. I think that it's really important that we understand that our words matter. And I think that when we're talking about humans, we do recognize that when we put labels on people saying, oh, well, you're a drug addict, that's a very negative connotation. Can we turn that? Now, many of my patients say to me, I'm a drug addict. Okay, you can say that about yourself, but I'm going to say you have a substance use disorder. But really try to work with individuals to bring them around and bring yourselves and the people within your organizations around to stop using those negative connotations, and understanding that there's a reason that people are in the situations that they're in. And so if we can help work with them and make it not such a negative thing for them, then maybe that will improve. Now, one of the things that if you guys don't take anything else out of this, please take this. When you say that a patient is non-compliant, you are assuming that you know why they're not getting the care that they need. You're assuming that you know why they're not taking their medications. You're assuming that you know why they haven't made it to 3 appointments. When it always goes way deeper than that. When I was working at a safety net clinic, and this girl was not homeless. She actually was 23. She had herpes keratitis and she was losing her vision. She was uninsured when I started seeing her, and she had been insured and she had seen she had been uninsured, but she was able to see an ophthalmologist. And the ophthalmologist at the bottom had written, patient is non-compliant with eye drops. Okay, well, let's talk about those eye drops he had prescribed. They were $350 for a month's supply. She had to take it 5 times a day. I don't know about the rest of you, but I don't take any medications 5 times a day. I would be terrible. I wouldn't take them either. But $350 a month. She worked part-time at Subway. $350 a month was she going to live inside or was she going to live outside? So that note saying that she was non-compliant was assuming he knew why she wasn't taking her eye drops. Now, I also did an A1C on her and her A1C was 12, but that's a whole other story. So that's just a really good example. But also, using the examples of our people who live outside, are people who don't have access to a phone, who don't know they have appointments, people who are supposed to be relying on Medicaid transport, and then they don't show up to their appointments. They can't call you. They don't have a phone. Medicaid transport just says, oh, they didn't show up. So when we say a person is non-compliant, we are assuming negative on their behalf, and we are assuming we know why they're not making it to appointments. So we know that street medicine organizations benefit the community, and we know that it benefits the individuals we're serving. My goal is to improve the health of the people that I'm serving and will, in return, improve the health of the community around us. It also increases the trust of the healthcare system. I gave that example earlier of my gentleman with frostbite. That's not a one-time, that is not a one-time thing that happened, right? Like that wasn't the first person who came to me and said, I'm not going to the hospital. Happens all the time. But if I can earn their trust, then maybe I can get them then to be like, let's go to one of the FQHCs, or, let's go to the ER if it's needed. But also having us in place, it does reduce the ER use, right? Because you have people who would run out of their medications and go to the ER because they don't know who their primary care is, or they lost their insurance card and they lost their ID and they can't get into the system. So we're really working to improve the overall health of the people that we're serving and the community. And we know we're a benefit to the community. So one of the things that we do is advocate for balances in healthcare. There are so many imbalances in care for people who are living outside, for people who are poor, for people who are on Medicaid. And we really advocate to improve education about that. For me, I like to present to other providers and let them understand the perspectives of us who are out in the community. A large amount, I will be the first to admit, a large amount of my patient population has a substance use disorder. A large amount, I'm saying 100%, but nothing's 100, right? So I'm gonna say 99% of my patient has a mental health disorder. It's not treated. Now, sometimes if you're involved with homeless serving organizations, um, then they're going to say, oh, well, not everybody who lives outside has a substance use disorder, not everybody, but the vast majority. And by us downplaying the substance use disorders and the mental health disorders in the people who are living outside, we're reducing access to services. If I can say, like, look, we have a huge problem with substance use disorder. We need help getting treatment, getting psychiatric care. We have severely mentally ill people outside. We need mental health, you know, support for our patient population, but denying or downplaying those situations is actually a disservice to our patients and hurts getting more services available to them. So it's really important that we advocate for them and being honest about what we're seeing. Do I have people who do not want healthcare? Absolutely. I do. I do. Don't force it on them. But if we can work with them, then maybe we can help them get that healthcare that they need. Um, and when they come to you or go to the hospital, better understand the networks and know that they have a support system behind them in healthcare professionals who can help them navigate the systems because they're complicated. Healthcare systems are complicated, and you all know that, right? And so it's more complicated for a person who's afraid to ask for help, for a person who, since childhood, has felt a bias against them because they were poor, because they were homeless. So they're not going to ask questions because they don't want to look dumb. So I left 13 minutes for questions. I will answer one question that I saw, if that's okay, and that was what to use instead of the word non-compliant. I say barriers to care. What are your barriers to taking your medication? What are their barriers to making it into their appointment? Someone else said, just write it in the chart, document it, like could not afford their medication, describe it. But non-compliant is such a biased term, in my opinion. Ashley, do you have questions?
All right. Thank you so much, KK, for your presentation today. There was a lot going on in the chat.
Oh,
But
well,
we
good.
we do have a couple of questions, and I will start with the first one, which you kind of talked about a bit, but maybe you want to elaborate. Can you explain your choice of using clean, dirty versus used, unused, or sterile used when talking about substance use? Clean, dirty can be very stigmatizing.
Yeah, yeah. And I know I said that. I don't use clean or dirty. I use new or used. Right. That's what I use when I'm talking to my patients. I do. Yeah, and you're right. When I'm talking to patients, I'll say, like, do you have access to new? So interestingly, where we are in Kansas and Missouri, needle exchange programs are not legal. There is a really good one at Casey Cares, and everybody knows it's there. The state knows it's there, and so we do not have a needle exchange of any type because it's not okay in either state that we're in. So that makes it a little bit difficult there. But when I'm talking to patients, I do say, can you go to the exchange and get some new ones? Can we help you so you don't have to use needles that have been used by someone else? So that's what I do in that circumstance. And what was the rest of the question? Sorry.
Uh, clean versus dirty, used, unused, sterile, used when talking about substance use. Oh.
Yeah. Okay.
So I will add to that. You had mentioned Casey Care has a needle exchange program. As of Monday, that program was shut down.
Oh my gosh. Wow.
Yeah.
I
They
didn't know
are
that.
still, yeah, they are still accepting needles, but they no longer are allowed to give them out, which is very unfortunate because it was the only one in the city.
The only
Um,
one that I know of in the state. And I don't think
yeah,
they're
in the state.
because they're illegal. Wow.
Yeah.
No, I didn't know that. That's awful. That's awful.
Yeah. Hopefully, that changes, but we'll we'll see.
For sure.
Okay, your work is amazing. Thank you. I'm sorry if I missed it, but how are you funded?
Um, we write grants. I'm a grant writer in addition to a nurse practitioner and whatever. But most of our funding is through grants, and also community support, local support. When I started the organization, it was 100% volunteer organization. We were 100% volunteer for 5 years. In 2021, we hired our first staff. And then now, so we had our first year that we hired people, we had 4 staff members. I actually now have 25 full-time staff members. And we keep writing grants to get support for the work that we do. And part of that, like, because we work with people where they are, we're helping get people off the streets. And it's evident. Our medical respite, over 50% of the people who have been in our medical respite over the past 3 years have not gone back to the streets. They've gone into traditional transitional housing, apartments with family, things like that. And so it really does work. I think one of the things that we have to recognize is that there's not a blanket response to homelessness that's going to be effective. And it takes working with individuals one person at a time, which is very, very difficult. It's expensive and it's labor intensive. But so yes, so we get a lot of grants.
Right. I just see one do you guys partner with any dental providers for like a all-in-one stop shop?
Yeah, we have
I'm
on
reaching.
Wednesdays, we have an oral surgeon who he does extractions, right? Because he's an oral surgeon. We actually have we have an X-ray machine. We have a face, like a I don't know what it's called, some kind of special facial CT in our one of our clinics. We have 2 dental chairs. So he does extractions. And then on Thursdays, we have 2 dentists who volunteer who alternate weeks and they can do more like cleanings and fillings and things like that. So we are our dental care because people come and we see, they see 10 to 15 patients every day that they're there.
I like your story of you building trust and follow-up care with a person with frostbite. Do you have any additional ideas on getting folks into more regular facility-based care?
Yeah, I mean, I think that it takes time. One of the things that we do for our people who are respite, we get them into primary care services, and we will go along with them. Another thing that we do is we have a relationship with specifically Casey Cares in Kansas City, where we have a standing appointment on Wednesdays at 1 o'clock, which I just learned about. One of my nurses has established it for a long time. So if we have a patient who tests positive for HIV, hepatitis, syphilis, then she can take them on Wednesday at 1 o'clock to get labs and to get seen at Casey Cares. And so if we can, and she'll go with them too. And so if we
That's
go
great.
with them, then that will help reduce their stress about going somewhere. And then we can help interpret some of the information that they get. Because one of the things that happens is people, they don't know what they were told. They're in a state of stress for whatever reason. Well, because they're always in a state of stress. Honestly, my patient
Mhm.
population is in a state of stress 100% of the time. And it's always, you know, survival mode. But if we can help and we can help navigate that, they'll come to us with like, these are my instructions and I don't understand what I'm doing. And so just working as that piece there. The medicine that I practice is not hard. It's complicated. And I know that seems weird, right? But it's complicated by so many other things. And so if we can help break down some of those complications, it will make the medicine piece easier and it will help people to get into primary care clinics. Now, listen, I've got people I've been seeing for 10 years who will never go anywhere else. That's fine. We'll continue to see them, but we really do work to try to get them in. And sometimes it takes a lot of trust building.
Yeah, I didn't see any other questions in the Q&A pod. However, I did see one come through the chat that I pulled really quickly. Are there other healthcare service providers like yours in various states? Are you planning to collaborate with housing providers?
Okay, so yes, there are street medicine teams all over the United States. Actually, in 2024, we hosted the 20th annual International Street Medicine Symposium, and we had people here from 35 states and 15 countries. There are tons of street medicine providers throughout the United States. Everyone looks different though, right? So as I mentioned, ours is independent, nonprofit. Many street medicine teams are under the umbrella of either a health system, an FQHC, a school of medicine, something like that. So yes, there are all over the United States. Um, and we work with them. We work closely with them. We have a good relationship with all of them. And then what was the other question?
Are you planning to collaborate with housing providers?
We do collaborate with housing providers. So we don't house. That's a nightmare. But what we do is we do the coordinated entry piece. We will do housing assessments. We do, for those of you familiar with housing assessments, they're called the VI SPDAT, if you know what that is. And so that is the first piece to housing to evaluate whether someone, I'm going to be honest, whether somebody's about ready to die so they can get housing. It's a terrible way to say it, and I said it because that's the way it is, and it's horrible. But we do VI SPDAT. We're very active in the continuum of care that works with HUD to get people housed. So, and that, like in our respite, we have a dedicated peer worker who's a case manager there. She's the reason people are getting off the streets because she has such a strong relationship with so many housing providers. So while I say we don't do housing, we do a lot of the legwork for housing, if that makes sense.
So I saw one other question. It said, can I get the name and number for the grant writer? That would be you.
Me. Yeah. So, I had a slide that had my name and number on here. I'm KK. My email address is Janelle, JAYNELL, at caribbeontheboulevard.org. I can't see the chat, so I can't put it in there. Otherwise, I would. And you text me. My cell phone number is 816-803-2705. I'm happy to help with that. We have right now, I think our budget this year is a little over $7 million, but that's because we have a huge capital campaign where we are renovating our medical respite. We just purchased it in November. We've been there for 5 years, but we've been using the space and it needs massive renovations. We also have a very good system for tracking grants that we've developed, and it's very helpful. Grants are complicated and difficult, and we actually have a great system for it. So you can text me or shoot me an email. I'm happy to answer questions if I can. Like, I don't have any formal grant writing experience. The reason I write our grants is because I hired people back in the beginning to write grants, and every single time I did, because our work was, it's so convoluted. I ended up writing most of them. And I'm like, why am I paying somebody? And then we didn't get them. And so I found that we've been more successful if I'm able to really tell our story. I know our story. I'm deeply involved with all aspects of the work we do. Not everybody can do that, and I recognize that, but I have an amazing team. My employees and my volunteers are the reason why Caribbean on the Boulevard is what it is. It's not me, like I have the leadership, but like these people are amazing humans, and the support that they give to our patients are unparalleled.
There was a lot of praise in the chat about your volunteers. They were
Yeah.
saying they must be amazing. So yeah,
I mean, some of our
yeah,
volunteers have been with us for 9 years, and that
yeah.
speaks volume. I think for us, for me, that speaks volumes to the work that we're doing, that they're seeing that we're
Hmm.
doing what we say we're going to do, because you don't
Yeah.
have healthcare providers who want to volunteer to something that they feel is a waste of time or not really doing what they say they're doing.
Um, so we're about at the top of the hour, but there was one fun question in here. I kind of wanted to know too. Where did KK come from?
My name's Janelle. My mom's name is Janelle. So when I'm the youngest of four by a long, my brothers are 9, 10, and 11. When I was born, the plan was to call me Janelle K, which is my middle name. And
Mm,
when I started talking, I said KK. And because I was the youngest and it was cute, it stuck.
it's stuck.
Yeah, like a lot of people think, oh, it was like an older sibling. No, I named myself, which is kind of appropriate for the way I am. But yeah, so
Love that.
Janelle is my mom. I'll answer to it, but nobody calls me that.
All right. Well, we don't have any questions, and we really appreciate your time today and your presentation. Um, guess we will go ahead and end it here and we'll connect offline.
Okay,
Okay.
thank you all for having me. Everyone have a great day.
All right, you too.
Bye-bye.